so much. Today I'm going to be talking about the role of MPTLT before a surgical intervention. So traditionally, we all know how to treat glaucoma. We all usually start off with a medical treatment, and then if pressure is uncontrolled, we may try a laser as a temporary procedure like ALT or SLT, and then consider a surgery if intraocular pressure is uncontrolled. And the conventional diode laser is the last resort, especially for painful blind eyes. But today, with the option of Micropus, we have raised this into earlier way of managing patients with refractory glaucoma, or sometimes even as a primary modality, especially to control the intraocular pressure. So I would like to say it is a temporizing measure to control the high intraocular pressure in patients whom we have to do an immediate surgery, and also to delay the need for a surgery which may be more complicated, to delay the frequent post-operative visits. Like Professor was also telling that in the current pandemic, we've also been changing our paradigm from incisional surgeries to go for more non-invasive procedures with lesser post-operative visits. So when do we use it? Of course, in uncontrolled intraocular pressure with failed medical therapy or a failed trap or a tube surgery, in eyes with fairly good visual potential, in eyes with advanced field loss. When we intervene, there may be a chance of macular shutdown, split fixation, and also in eyes to control intraocular pressure before a very high-risk surgery, and in angle closure glaucoma, where surgical intervention is definitely very risky. It is like a time bomb operating in these eyes. So it is always better to control the intraocular pressure before going in for incisional surgery. So why do we have to do this? Because we need to control the intraocular pressure to preserve the vision loss, to prevent any progression, and also to avoid the high-risk complications with an invasive surgery. How does it reduce intraocular pressure? We all know by three mechanisms. It reduces the aqueous secretion, it increases the uveous scleral outflow, and most importantly, the trabecular outflow as well, because of its effect, which is thought to be similar to that of pilocarpine, because it acts on the longitudinal muscles of the ciliary longitudinal fibers of the ciliary muscle, which causes a displacement in the scleral spur, changing the configuration of the trabecular meshwork, and thereby increasing the trabecular spaces and increasing the outflow. So a success, again, depends on multiple factors. It could be depending upon the type of glaucoma for which we are treating, follow-up duration. Some people follow it up for 6 months and they say that the success is good. Some people follow it for 2 years and the success may not be as expected to be good as it. So we have to interpret each result or each study with caution. And also whether we are using it as a primary or a refractory treatment, and also how they have defined the success, whether it is a total success or a qualified success or a complete success. And also depending upon the percentage of IOP reduction that they have used in their studies. Many use it like less than 21 with only 20% reduction, 30% reduction, or 40% reduction. So based on that also the success may be varying. And also with the complications involved, the prior history of glaucoma surgeries, and many concurrent procedures. Sometimes we may combine it with a cataract surgery. So we do not know which is doing the effect. And also depending on the baseline intraocular pressure, the power settings, and most importantly, the age of the patients. Because younger patients, it does not really do so well. A day at Arabian, I work in a tertiary eye care center at South India, and we see close to 350 glaucoma patients per day. And in an average, we see around 280 patients in a day and 80 new patients per day. And out of which we have probably around refractory glaucomas will be 10 per day. So salvaging these eyes is definitely a biggest challenge. We all know that Arabian and cost effectiveness is hand in hand. So we have performed till date around 175 Micropus procedures, and we usually schedule these according to the number required, and usually it is done in 2 days in a week. And we prioritize the patients as per the risk category. Why I said cost effective is because unlike what Professor was telling, he uses a single probe for each patient. We use single probe for 5 to 6 patients. And we also have a satellite hospital nearby where we mobilize this instrument there and we share it there. So the procedure is also a little different because we do not do it under subtenons anesthesia. We have been doing it under peribulbar anesthesia. The reason why we do not do it under subtenons anesthesia, sometimes I have seen that the tip of the probe sometimes gets, the conjunctiva is very loose. It may sometimes get stuck into that. It may cause an extension of the opening where we make for subtenons anesthesia. So the Arabian Micropus Realty study was basically the objective was to evaluate the short and intermediate term outcomes on the efficacy and safety of this procedure in eyes with refractory glaucomas. It was a prospective interventional study. 77 eyes of patients with refractory glaucoma were enrolled. Surprisingly, we had 48% of these patients were angle closure glaucomas. We had selected more patients who were at risk of having an intraoperative complication or to reduce the intraocular pressure before we intervene for a surgical procedure. A single surgeon and a standard laser setting was used. Initially, we started off by only 1,750 with a 0.5 and 1.1 on and off cycle, and we treated for 180 seconds. So this is a video. I'm going to skip this because we all have seen the previous speakers sharing that. So the post-operative regimen is we usually continue all the anti-glaucoma medications as before. Steroid and antibiotics are used 4 times a day, and it is used over 4 weeks, and it is tapered. Cycloplegics are used only whenever necessary, depending upon the anterior chamber reaction. We usually measure the intraocular pressure on the day 1, and then we review the patients after 2 weeks or after 1 month. And because of the study, we have called these patients at 2 weeks, 1 month, 3 and 6 months. Best corrected visual acuity, intraocular pressure, and the number of AGM used were noted. Anterior chamber reaction, pupil diameter, complications were noted at every visit. The success criteria, because we wanted to see what was the success at different criteria, we look up into all 3 categories, like success at 21 millimeters of mercury with a 20% reduction, success at 18 with a 30% reduction, and success at 15, less than 15 with a 40% reduction. So complete is without any anti-glaucoma medication, the control of intraocular pressure. A qualified success is with anti-glaucoma medication. And a failure was defined as a need for a repeat treatment to control intraocular pressure after 8 weeks or a need for a repeat surgical intervention. So the results, our results clearly was almost similar to what Professor had shared. So we had a baseline high intraocular pressure of 34, and at week 2, we had 22.53 with a significant reduction. And this was consistently lower at month 1, month 3, and it maintained at 19.39 at month 6 with a significant reduction from the baseline. However, as Professor mentioned, even in our results, we do not see any major change in the number of anti-glaucoma medication used from the preoperative readings, as well as the best corrected visual acuity also did not show much of a change. So if you see the percentage of IOP reduction, to start off with baseline, it was 34, and then at the end of 6 months, it was 40% reduction in intraocular pressure. And looking at the Kaplan-Meier survival curve, this we used it at 18 millimeters of mercury as a success criteria. It was found to be 85, 78, and 72 for 6 months, 1, 3, and 6 months respectively. So the success criteria as compared with different IOP variations in IOP, like the 21, 18, and 15. So the complete success at 1 month was 60, and then the qualified success was 89. This is for the 21 millimeters. And when it was changed to 18 millimeter, the success was 85. And when it was changed to 15, the success was 68. So if you see at the end of 6 months, this was maintained probably with the qualified success of 75.7% at 6 months at 21 millimeters, 72 at 18, and 52 at 15 millimeters of mercury. So the post-operative visual outcomes, if you see, most of these patients had stable vision. So we did not see much of a decrease in visual acuity. However, a small percentage of patients did have a decrease in visual acuity. The reasons for decrease in visual acuity were either a vitreous hemorrhage, cystoid macular edema, and 1 patient had corneal decompensation. There are many complications associated with the laser procedure, but we did not see all of them. We did have a few patients going in for retreatment. There were 2 patients who developed vitreous hemorrhage. There was 8 patients who had a decrease in visual acuity, and 11 patients had progression of cataract. So comparison with the conventional procedure also showed that the conventional procedure had more complications, more phthisis reported. And compared to the other studies which have been reported, our success was very much similar to that. We had a success of around 75%, which is very much similar to all those studies which were reported. And our drop in visual acuity was also slightly lesser than what was reported. So it was 10% in our study. So I would like to conclude by saying that the MPTLT is definitely a promising option in temporizing the high intraocular pressure before any filtering surgery, especially in eyes with refractory glaucomas. It increases the safety and reduces the risk of devastating intraoperative complications. Sequential micropulse followed by a combined triple surgery or a trabeculectomy in angle closure glaucoma may prevent the sight-threatening complications associated with the surgery or with the glaucoma as well. Newer protocols of MPTLT are being explored to study its role as a potential replacement or an adjunct to medical therapy. Thank you for patience.